As we're all aware, PHOTON was a pivotal phase 2/3 clinical trial that compared 8 milligram of aflibercept head-to-head against the standard of care, which is 2 milligrams of aflibercept dosed every 8 weeks after an initial 5 monthly injections. Now, the 8 milligram of aflibercept arm received an initial 3 monthly injections, and then patients were randomized to receiving it every 12 or every 16 weeks, with the primary endpoint of being non-inferiority in visual acuity at the end of the first year. Now, both arms, the 12-week and 16-week arm, reached or met its primary endpoint at a level of high statistical significance. And so we know from that PHOTON data set that aflibercept every 12 or 16 weeks after 3 initial monthly injections of the 8 milligram variety is highly effective in treating DME. This post-hoc analysis wanted to look under the hood of the engine, so to speak, and compare across all PHOTON patients, irrespective of treatment arm, what they looked like and what their treatment journey looked like over that first year of the study based on how severe their disease was at baseline. And so the easiest way to do that was to look at central retinal thickness at baseline as a surrogate for disease severity and split patients up into quartiles. Quartile 1 being the least severely diseased retinas that had on average a retinal thickness of less than 360 microns, versus quartile 4, the most severely disease-stricken retinas, the thickest, most swollen retinas at baseline, which on average had a central retinal thickness greater than 600 microns across all 3 treatment arms. The idea of this post-hoc analysis was to look to see how vision, anatomy, and treatment burden changed across all 3 treatment arms based on where they started. And what I can tell you, Connor, is if you look at quartiles 1 and 2, and you look at folks who were treated with 8 milligram of aflibercept either every 12 weeks or 16 weeks, is that their treatments from an anatomical as well as a visual acuity standpoint virtually mirrored the patients receiving 2 milligram of aflibercept every 8 weeks, the standard of care, meaning that they achieved a very similar visual acuity as well as central retinal thickness reductions across that first year they were followed, despite receiving on average anywhere from 2 to 3 fewer injections. What that means to me as a retina specialist is that if you have a slightly less swollen retina at baseline, you might be able to get away with treating a patient every 12 or 16 weeks potentially after only 3 initial monthly injections. So you can kind of immediately fast track them. This kind of is case in point and basically is proof of concept of that model of treatment. Now, where the data really becomes interesting is when you look at the more severe, hard to treat patients, the folks who have more swollen retinas at baseline. As you can imagine, those patients had slightly lower visual acuity to begin with, but if you compare them across all 3 treatment arms, patients on average achieved a very similar absolute number of ETDRS letters. They also achieved very similar anatomical gains, irrespective of treatment arms, but the folks who received 8 milligram of aflibercept did so with less overall injections in that first year. Now, the magic of this post-hoc analysis really lies in looking at quartile 4, those most swollen retinas, and looking at patients and their rates of fluid reaccumulation across treatment arms. So what do I mean by fluid reaccumulation? Well, one common data point that you can compare is 8 weeks post most recent monthly injection. So what that means is the folks who received 8 milligrams of aflibercept had 3 monthly injections. So if you look at week 16, that is 8 weeks after their most recent monthly injection. If you look at fluid reaccumulation from week 12 to week 16, you can see that there was a modest increase in central retinal thickness that occurred, on average, anywhere from 3.5 to just under 6 microns on average for the 8 milligrams dosed every 12 weeks or every 16 weeks. Now compare that against the standard of care arm, the 2 milligram of aflibercept arm that received 5 initial monthly injections. 8 weeks post the most recent monthly injection would have been week 24. And if you look at the CST in that 2 milligram arm at week 24, on average compared to week 16, there was an actually higher increase in CST that on average was about 55 microns thicker. So if you're comparing across treatment arms, you can see that in quartile 4, folks only achieved a small bump in CST if they received 8 milligrams of aflibercept, but patients who received 2 milligrams of aflibercept had a much higher trajectory for fluid reaccumulation. What that tells me as a treating retina specialist is that folks who have more swollen retinas at baseline have more circulating VEGF that needs to be suppressed, and that also reiterates the importance of having a higher dosed VEGF agent on the market that can contribute to that initial VEGF suppression, particularly in the more difficult to treat DME patient population. Based on our last conversation, we know that there's so many more medicines crowding the market. There's new treatments for previously untreatable disease conditions and diagnoses. So there are no shortage of patients in our retina clinics. The fact is we can use this data set and this post-hoc analysis to help stratify the patients that might be able to be fast-tracked into longer treatment intervals versus the folks who might require a little bit more TLC, the folks who will actually need to be treated more often. So if I see a patient and I know they fall into quartile 1 or 2, I can hang my hat on this data set and this post-hoc analysis from PHOTON to know that I can reasonably treat this patient without undertreating them and get them to similar visual acuity and anatomical benchmarks as if I was to treat them every 8 weeks with 2 milligram of aflibercept. So the fact is, I know I can treat folks with 8 milligram of aflibercept immediately every 12 or 16 weeks after just 3 initial monthly injections. And it also lets me know that the harder to treat, more treatment recalcitrant patients, the folks with more swollen retinas at baseline, are going to be the ones that I'm going to have to place a premium on for follow-up to ensure that they're not being undertreated, because there is a higher level of circulating VEGF that exists in that patient population, which is why a more durable agent, a higher formulated agent like 8 milligram of aflibercept is required for that population. I think it's a great question. We're privileged to be in the space in the time that we're in retina. I think I mentioned it the last time I spoke to you, but the previous 5 years of time has seen more innovation and more medicines brought to market than the 10 years prior to that. So we're really in a golden age of retina as far as therapeutics go. And that includes having second generation anti-VEGFs like 8 milligram of aflibercept on the market. It also includes new modes of treatment, whether that's gene therapy through intravitreal or subretinal or suprachoroidal delivery, which several companies are doing. It also looks at innovative and novel ways of treatment, looking at intracellular treatment paradigms like tyrosine kinase inhibitors. And then ultimately, it all kind of comes to a head when you're the patient, because as a patient with these highly burdensome diseases, whether it's diabetic macular edema, like what I've been discussing with you with this post-hoc PHOTON analysis, or other retinal vascular diseases like geographic atrophy or wet macular degeneration, we now, as a patient, you now have the opportunity and ability to get involved either through clinical trials to get these medicines a little earlier, or now in this space that we live in where we have so many newer medicines hitting the market, you now have the opportunity to have your choice of what treatment agent you can go to. And that's very important because not everybody responds the same to a given medicine. Whether it's the data set I'm presenting or there's data sets that were also presented at ARVO, that, we talk about averages, but there are always outliers. And so if you are an outlier patient, it's great to know that if one agent may not do the trick for you, you have another one or another 2 or 3. So I think this is the golden age of treatment to be a patient with retinal vascular disease. And as a physician that's interested in the clinical research that brings these medicines to market, it brings me great joy to know that I can play a role in getting these medicines to my patients a little sooner and giving them options, because oftentimes it's just as much about the hope as it is the science that drives the innovation. And that's just as important for the physician as well as the patient.